Karibu sana, welcome. Yes, so today, guys, as you know, we're going to have a beautiful session with Dr. Gichoya. She is the interventional radiologist. You know, you can't be an interventionist if you don't know what you're intervening. So basically, she's gonna teach us a lot of anatomy, some good pictures, I think, for MRIs and all that. Maybe somewhere, I don't know. I don't want to preempt her slides. So we're waiting for more people. Can you just type where you are so that we can start from there? Let us know where you are in the chat box. Welcome, MT. Sahiba, welcome. Paul, karibu sana, welcome. Guys, can we know where you are at the moment? As before we start, we're gonna be starting the next 1 or 2 or so minutes.
5 minutes.
In 5 minutes, yes.
Okay.
So, I'd like to know where you are. And last week, I just asked Victor, I don't know if Victor is in this group right now, but I wanted to know what topics you like to be taught so that I can look for people to teach, because we have a group whereby we can have many people to come on board and teach you guys. So I wanted to know that.
Can you see my screen?
Yes.
Okay. Okay. Give me like 5 minutes.
Sure. Sure. Okay, guys. I think AV says that should be in Kenya or something, I guess. Paul, where are you? Are you at? Felix? I think I know where Irene is in the US. Lillian? Okay, Felix is in Kenya. Everybody, where are you guys at? Where are you tuning in from? Nairobi, Kenya, Lillian. Awesome. We have 15 people already. Paul Njeru, Kenya. Nairobi. Mogeni, Kenya. Perfect. You guys, I mean, we have been doing a pretty decent job, and most of the time, Dr. Judy loads the videos that we get on the YouTube, so you can always get them there. My slides, I think they should be, we're creating like a website where you can get all this information, and we plan to create that website whereby you can get as many questions as possible, and we will be running it, many of us. I'm looking forward to engaging so many people out there so that we get the best out of our colleagues who have already done the USMLE exams, moved to the US and all that. So just remind your friends, wherever they are, they can come in at any point so that we start. I see Dr. Janice Newsom. I'll give her a chance to say something right now, if she can hear me.
Good morning. Good morning. I absolutely can hear you. I didn't hear much before that, but just wanted to say I'm excited to learn a little bit about neuroanatomy gamesmanship, because this is important whether you're first year or a 20th year. So I'm excited for this lecture. I want to say thanks to everyone on this call that joined the call last week. And, you know, I'm going to be on this journey with you, and congratulations to the organizers for this. I think that this is incredibly important. And so I'm going to get my pen out and my polling thing out so I can get involved and try to answer some of these questions here.
Amazing. So maybe just to remind those who might have joined us today and don't know Dr. Newsom, she is an interventional radiologist. She's a teacher. She teaches at Emory. She works closely with Dr. Judy Gichoya, and she loves sessions like this, and that's why she's here with us. And as I told you guys, we're going to engage people who have interests of teaching and helping the others, and that's why she's actually joining us today. And I mean, I would like to know what you like to be taught, which subjects are difficult for you. Just type them somewhere, throw them in for me. You can send to the panelist group, and or you can send, I believe, we can have a poll later to see which subjects you're really interested in. But we have a couple coming up. We have ophthalmology coming up. We have ECGs, cardiology coming up. We might not have somebody to speak next week, but I have something on neurology. So I think we can, and I'm sorry, I want to apologize that we changed the timing to—
It's gonna go back to 10. It was a mistake.
Yeah. So every weekend we'll be doing at 10. So maybe some of us try to come in an hour earlier, but that's okay. So I'm gonna give it to you, Judy. Go ahead.
Thanks, Dr. Newsom, for joining us. Did you say hi?
Yep.
Okay, good. Okay, so I got this task. It's not an easy task. I tried to get someone to do it, but I didn't get it. So it's on neuroanatomy, gamesmanship. And really, this is going to be a companion lecture to the one that Walter gave last week, okay? Because it was really good. It's available and good for you to review. Can you guys hear me okay?
Loud and clear, Dr. Gichoya.
Okay, good. So last week, if you joined us, then you know that, okay. So one of the things that I wanted to start off is that we've created a YouTube channel, you know, a playlist for you to watch the previous sessions. Walter did the first two. So please watch, leave some good comments. If you have bad comments, send them to us. But anyway, you can leave whatever comment you want. But so if you search this on YouTube, you'll find the list. Okay, so Walter said that 29th August, maybe we have someone. But the time, I just want to emphasize that it's going to be 5 p.m. Kenyan time, not 6 p.m. like today. And then we have something coming up on cardiology. So, you know, I don't know if the big funds, I need for us to test something that we're going to use today. So between Arsenal and Manu funds on the call. So let's see how we think. So to participate, you have to go to this link, paulev.com, Judy Gichoya 673, and you have to say Niganikali, Manu, ama Arsenali. And this is going to be a very interactive talk, so I really need quite a bit of people to do this. So very concerning that there's no one who's doing it. I need to figure out if the system works, okay? That's what I need for you to do it.
I'm not sure where I should be, where the link is myself.
This one.
Should you click on it or?
Can you see paulev.com?
Yes, I can see that.
Judy Gichoya 673.
Okay, let me just search it on. Thanks.
Oh, okay, maybe I need to activate it. This is why we need to do this. So, guys, could you put in the chat if you're able to? So I don't see any responses. So, because we need to figure out. Okay, okay. I see someone is Arsenal fan. I need a little more participation because most of the cases we'll do will require you to be on this side and participating from here. So, get a better mouse pad. Okay. Good, good, good. Okay. Really? It's 50-50? Okay. Okay, good. Okay, so I'm going to stop the poll, and it turns out that most of our funds here are Arsenal funds. So, okay. So we're gonna, don't close that link because you're gonna be using it a lot, to be honest, during this talk. So, yeah. Now let me figure out how to, it's a new system, so bear with me.
Dr. Gichoya, do you need some IT help?
Okay, this is the kettle calling the pot black, the pot calling the kettle black. But okay, so I need to, very good. Okay, guys, just give me 1 second. Participation is good because I know that it's going to work. I just need to find my mouse. That will be good now. Okay, so last week, if you joined us, you knew that I did not support Walter through his presentation. And the reason was that I was called to do a case. And so I just want to walk through that case together. And so could you touch the area that you think is abnormal here? That's your task. And I'm going to go fast because we have quite a bit of cases to go through. Okay. Okay, guys, I need like more participation. If you don't, then I'm not gonna spend the time to make the, okay, good. Okay, okay. Okay, so we have quite a number, although people are not participating as much, but that's good. So I'm gonna lock the response, and I'm not looking at my chat, Walter, so if there are any issues, technical issues, let me know.
I'll try to take care of it.
That's because I have some mouse problems.
So the question was, how do you point? So you have to point to the abnormality from the poll everywhere
Yes.
thing. So not on this particular screen.
Yes.
So Dr. Gichoya, if you want to unlock your poll everywhere just once more time and give folks a chance to touch the abnormality.
Okay, good. Oh, good. Okay, so you have to work on the poll, and Kima, thank you for sending the link. You know this? Oh, good. Okay, good. So I'm going to stop the the response, and then so this is the area of abnormality. Kudos whoever did that. This is the aorta. So, and I'm going to just walk through this case for last week. What's the diagnosis? So I already showed you that this is the area of abnormality. So in this case, and we are all going to learn how to use this, but in this case, you just have to type your answer. You don't have to point, but you do have to be on the, yeah, okay. Yeah. I'll wait for five words and then I'll lock the poll. Okay. So you have an aortic aneurysm, sure. Obstruction, kidney stone. Okay, so I'll lock this and go back through the case. The only problem with this view is that it's not very mouse responsive. So when I did this, I said touch the abnormality, and you can see that this is the area of abnormality here, which in this case, what we call this is a pseudoaneurysm. And this is just a false, it's just this false wall, and it's a collection of blood because this is the aorta. And if I'm giving contrast through a CT scan and you can see blood where it's not supposed to be, it means it's just a contained bleed. Very, very dangerous, because if it bleeds, then it's just going to pour into the abdomen and the patient dies. So this is a CT scan of the abdomen. When you look at a CT scan, you're being put into a tube. And in this case, the right side, what you think is sort of like your left side. So this is my left hand looking at this side. It's usually the opposite. So this is the right side of the patient, and this is the left side of the patient. So this is the spleen, and this is the liver, this is the stomach, and this would be the pancreas, and these are the blood vessels. So this was an unexpected finding here that should not be there. And so I just want to go back. So this is the liver, this is fat, this is the pancreas, this is the aorta, this is abnormal fluid collection, this is a distended stomach, and no one pointed to the spleen. And so don't worry, we're going to go to neuroanatomy. I want to ask you another question here. Go back to the poll and say, how would you treat this pseudoaneurysm? Again, I'm just going to wait for just a few responses.
Dr. Gichoya, unlock the poll.
I think it's unlocked. Yeah, I think it's unlocked. Okay, so there's an option for a stent, embolization, stent graft insertion. And I'll start hiding some answers, but this is, I just wanted to sort of close the loop from last week from this case. Stephen is also fine. You can also type in the chat, by the way, for the text answers. There'll be a lot of touch things too, but it's okay. You can also answer in the chat. That's okay too. I understand, like sometimes you're just on your phone and difficulty. So embolization. So what embolization is a good answer. It's difficult to do a stent graft, and this is because you need to be, if you want to put a stent graft, it's usually like a pseudoaneurysm or an aneurysm of the aorta, and you're putting a stent, which is just like a pipe, to protect the wall, so that if the aorta ruptures, then you can you can have control over that. I don't know what USGC is. So, and so embolization is what we end up doing, and we're cheating a little bit. So I'll lock that, and then, and so obviously I'll change some history here, but this is a patient with gallstone pancreatitis presenting with abdominal pain. So the vital signs were stable, and the CT scan was performed to evaluate for abdominal pain. And so what are your differential diagnoses for acute abdominal pain? What do you think? And you can either put, I prefer for people to use the poll. It's not mandatory, but if you cannot, the chart is fine. But the reason is that okay, interesting. If you put here, because it's going to set the precedence for the neuroanatomy lecture, which has a lot of touch areas. Okay. So on the chart, there's pancreatitis, peritonitis, appendicitis, away for, yep. You know, pancreatitis, peptic ulcers, lots of people say appendicitis, nephrolithiasis, you know. So the way I would approach, so I'm just gonna lock this poll. I like the participation now. And the way I look at sort of, looking at diagnosis for acute abdomen, I actually always remembered it by using anatomy. And I already went through some of the things that are, you know, in a CT scan, and based on this, then you can be able to say if your stomach is having a problem or your duodenum is having a problem, then that will give you abdominal pain. So kidney stones is good. The spleen, usually not a known cause, multiple causes of abdominal pain. The liver. And so this is a CT scan, and I'm just going to play the video to scroll through, and you can see that this was before the problem that I showed, the pseudoaneurysm that I showed. And so if you look at this point, I said this is the liver. So I didn't see anything on the gallbladder. Gallbladder is a very common cause of acute abdominal pain. And we have also the stomach. In this case, when the video plays, you'll see that the stomach has this collection, which is an abscess in this case. The pancreas is a very, very, very common culprit for abdominal pain. And also the kidneys, who are these guys here, can cause a lot of abdominal pain. And so I want you to mark this paper because it's a very good review of abdominal pain, and encourage you to just use it to refresh. This is like a 1-hour lecture, so we cannot really do quite everything at the same time. And so these are differential diagnoses of, in this case, it was a case of acute pancreatitis, and this would be the other things that you should think about. Remember, in females, you have to think about pregnancy, ectopic pregnancies, and like tubo-ovarian abscesses, but most of these other things came up. And also intestinal obstruction, I don't think that came up. And so I just wanted to recap that for us, when we diagnose acute pancreatitis, we are relying on clinical history and the labs, and usually would order lipase. And the role of imaging is just to help monitor for complications. So this is a very good paper that will go step by step of all those things. What are the causes for acute pancreatitis, and what are the complications of acute pancreatitis? And so what I want to emphasize here is that we saw something called an aneurysm, a pseudoaneurysm. And so you can see that this is a known complication. And the other one we saw was this pancreatic necrosis with an abscess and a collection, you know, an abscess that needs to be treated. And so the way you diagnose acute pancreatitis, there's one where the pancreas is just dying. And this is because the enzymes in the pancreas are very good for digesting food, but they shouldn't be anywhere else. So if they go other places outside the pancreas, they start to eat at the pancreas and at the other areas that are being where the pancreatic enzymes come into contact with. And so there's just some where it's just like inflamed, you know, just angry, but it's not, you know, leaking the enzymes or causing a lot of the necrosis, which is the death of the tissue. And based on those things, which is where imaging comes into a role, don't worry too much about this, determines the management. And so I'm going to show you the image that now had this is the collection, the abnormal collection here. And you can see that this is the heart. The pancreas would be sitting somewhere here, and you can see that there's a stent in there. And so you have to treat the collection, and what the treatment for the collection is usually called a cystogastrostomy. There are many other ways that you can treat this, and it's where you bring the collection that you want to drain close to the stomach, and you create a stent in between the two. And so in this case, you'll see that in a second case, you'll see that there's the pseudoaneurysm, but you see that stent in there that's communicating within the collection and allowing it to drain, okay? So this is something that I never saw throughout my medical school training. And so the management for the pseudoaneurysm starts with the groin access, or sometimes through the wrist. And here, what you can see here is that I'm puncturing an artery through the groin. This is the common femoral artery. This is the superficial femoral artery. This is the profunda femoris. And, you know, I'm putting a small catheter that's then going into the blood supply of the abdomen. And you can see multiple things. You can see this is an impression of the kidney. You can see that there are some vessels there. And I've labeled this for you guys because this is where my catheter is, and I'm what is called the celiac artery. And the celiac artery has a branch, which is called the splenic artery. And the celiac artery has a branch called the splenic artery. In this case, my arrow is kind of moved off, but this would be the common. So the celiac trunk gives rise to the left gastric artery, the splenic artery, and the common hepatic artery. And that then becomes can give rise to a gastroduodenal artery. So these arrows are incorrect right now. It's the projection of the presentation. And in this case, we have what was variant anatomy, and this is just a left hepatic artery. But usually the classical anatomy, and we'll spend some time if that's of interest to look through just vascular anatomy of the body, but looking through from an interventional radiology perspective. And so what I ended up doing last time was to bring the catheter further into the splenic artery. And you can see that it's enhancing in the spleen. And then I ended up going into what was that left gastric artery. And you can see something here that is correlating. You just have to believe me that that's the pseudoaneurysm. And you can see you have a big catheter and then a small catheter, and you can see something rapidly filling here. You remember I showed you that there's a cystogastrostomy that you can see the impression for. And so same thing here, you see this abnormal collection, which is that false lumen, which we call a pseudoaneurysm. And with my catheter in there, I'm able to put in many, many coils that ends up stopping the blood flow and treating this in this way, okay? So that's what's interventional radiology, and that's what myself and Dr. Newsom do, okay? So I will take a little bit of time, 1 second, to answer any questions about this case. So that was last week, then now we are here for this week. Okay.
Dr. Gichoya, how is the patient doing?
I did well, no more bleeding. Has a little bit of pain from the pancreatitis. That's what's being managed. Okay, so since there are no questions about the case, we will move to our thing today, which is neuroanatomy. And I'm going to move fast. If people are not answering, then I'll just move on, okay? So this is an MRI, and you know, it's really beautiful, and I'm not going to explain how MRIs are formed because I don't want to complicate things. But this is going to be the purpose of our work today, to try and figure out, can we use radiology to understand gamesmanship, to figure out where you are, or even just give you a basis to go and study and be able to look for one more screen here. You know, to look for a basis for, you know, how to understand neuroanatomy. And so when you think about radiology, you have to think about different views. And this is a picture of a wheelbarrow. You can look at it from the front, the side, with it. I mean, we don't have, I never had one of these growing up though, this one with an elevator, with something to put, not an elevator, with a jack or something. But you have to understand that you have to look at imaging in multiple views. And this is how I think you get to understand a lot of anatomy. And so if I sort of show these views for the brain using the MRI, this is a sagittal view, which means just someone is splitting your head into half, right? You can see the nose, you can see the tongue, you can see, so you're just looking at Judy from the side. And then this is an axial view where you're seeing, like you're cutting me across. And so you're looking from top to bottom. And then this is the coronal view, which is how you'd be looking at me, but you're slicing me, you know, like you're looking from front to back. And this is going to be the, like I said, this is a companion lecture to what Walter talked about last time, because I want to just sort of tie those concepts and to give you a foundation for understanding this, because Walter already talked about the sort of the gamesmanship from the questions and the buzzwords. Okay, so I'm going to play a top view look of the brain here. And remember, Walter talked about two cerebral hemispheres, the top things in our head. And this is like a very, very basic letter. If it's too basic, please type into the chat and let me know that, man, this is too basic, we need something more, and I'll move faster. So you can see that this is the brain. I'm just looking from top to bottom, going down. I'm looking at it in two different sort of views. And we're gonna walk through the anatomy from that. And this is a sort of a water-loving view here. And you'll see that I'm just looking through and I can see different structures. And so I just want, at this point, all I want you to remember is that these are the cerebral hemispheres and they start from the top, these two. And the way I like to understand my anatomy is sort of like looking at it and imagining this form of communication. And I'll walk you through that. And in this next section, what you're focusing on is what Walter described about this embryonic development, but I'm not going to talk about this. I'm just going to show you how do these things look like, because what happens is that you'll be asked to identify the midbrain on an MRI, but the question will not be what's the midbrain. It's going to be from where does this structure develop from? So you need to be able to identify the midbrain and then say, this is from the mesencephalon. Okay, you need to identify these, the T's, as Walter put them, the thalamus, the hypothalamus, and you need to say, this come from the diencephalon, and the basal ganglia here. You need to know that the cerebral hemispheres, if there's a mark there, that this is coming from the telencephalon. The questions sometimes are straightforward, but increasingly there are these two-level questions, which are very, very difficult. Because you need to understand, like, you already know that this is the midbrain, but you may not know the next stem. And so, if we look at, we're going to do a quick poll here, which is to say, could you show the anatomy? And here, I want you to mark where you think, so this is just a touch example. I'm going to give just like 30 seconds. Maybe I can start the timer here. And, oh, good. So where do you think the pituitary gland is? Okay, so most people are getting it correctly, where you can see the crowd there, which is here, okay? So that's the pituitary gland. And it usually has this shiny white spot. Most likely, if you're going to be asked about the pituitary gland, it's going to be on a sagittal view, okay? That's the, okay. Oh, okay. I see what's going on. It's my laziness. So the next thing was ignore the pituitary gland, but I want you to say where is the midbrain in this case? I'll unlock, sorry. Could you show it? Okay, just ignore this part. That's my mistake. Okay, good. So agree, this is the midbrain. Okay, I'm going to lock that, clear responses, and now I'm going to hide the responses. Could you point to the medulla? Okay, so I'm going to show some responses. Good. So this is the medulla where the crowd is, and this is maybe too low. This is the spinal cord. Okay, so I'm going to lock that, clear responses, and hide the responses. Could you show me where the pons is? Okay, I'm going to show the responses for the pons. Oh, sorry, I think it's locked. So Anne, please share the link again for the new people. And Kima, if you don't mind. Okay, so I'm going to show the responses. Oh, awesome. That's perfect. This is, well, I guess it's true. It's correct. And then the last one in this series is going to clear responses, hide them, lock the poll, but then unlock it now. And so I want you to mark where the cerebellum is. Cerebellum. Thanks, Anne. So we did midbrain, we did pons, medulla. Now we're on the cerebellum. Awesome. That's perfect. Okay, so I'm going to stop that. And I'm going to ask you to point to where the fourth ventricle is. Fourth ventricle. Okay, let's see. Okay, great. Yeah, so this is the fourth ventricle. This is in the canal now, the spinal canal. Okay, I'm going to clear responses, and the final one is to show where do you think the lateral ventricle is. People are very, very good here, Malta, with the anatomy. We don't need this lecture.
I think it's for me. I think I'm learning a lot.
Okay. Okay. So. Okay. So definitely not here. This is the fourth ventricle. Okay. So We are going to go through the sagittal anatomy recap. Really, this is not an area of sort of deficiency, at least from the people who are participating. It's very, very clear. I went through multiple structures. I said, this view, you're looking sagittally, so someone is splitting your head into half, okay? And as you look here, you can see this is the pituitary gland. Very easy to identify because of this bright spot. And you should remember, you don't really need to know the physics or anything for the anatomy. You just need to know, I'm looking at a CT scan, as an MRI, this is the anatomy. These are the ventricles. This is the cerebral hemisphere. It's just sort of split in the middle. This is the cerebellum. And this is the fourth ventricle. This is the third ventricle. And I have another picture for the ventricles that we'll go through. This is the midbrain. Remember, Walter talked about, the connection sort of between the cerebrum and, the brainstem, which goes through to the spine, being the, Lydia, you raised your hand. You can just type what you, the question really for the, you can type the question on the chat, Lydia, and Walter is gonna monitor it. And so this is the corpus callosum, and this is important because this is sort of the communication between the two cerebral hemispheres. They talk to each other, and the pathways that go in through this corpus callosum. And then you can imagine if the head needs to talk to the spine to allow us to move and do all those things, then it does this through the brainstem. And so we're going to just dive in a little bit on these cases. So I'm going to forward my slide here pretty quickly, just because we went through everything, which would have been the polls. Okay. So here we'll do another mark here, but let's start with I'm going to hide the responses for a bit. Let's start with the thalamus. Could you mark where you think the thalamus is? Okay, I'm going to show responses. Good. Okay, not here, but I'm not going to say those two areas because you'll be marking them soon. But yes, so the thalami are always kissing, the midline here. Okay. I'm going to clear. Yes.
Dr. Gichoya, could you just give us a few seconds more to switch from the poll everywhere to back to the lecture? Because when you say not here, people are still switching over.
Oh,
and you can only do this if you have two screens, but if you only have one screen, you have to switch in between. So yes. Just a few more seconds, thanks.
Sorry. Okay, guys, so these are the thalami. And most people check those areas correctly. I'll pause, I'm moving too quickly. And then I'm going to clear my responses here, and I will ask you to mark where the caudate is. Caudate. Okay, I'm going to lock. Ooh, nice. Lock the poll. Give us a few minutes to see where you ended up. So definitely the person who's here, this is sort of like the internal capsule. Remember I talked about the corpus callosum. The corpus callosum would be here. The corpus callosum would be here. Okay. And this is just the same view where you're looking at different views. But for the caudate, majority of the people are correct. This is the area of the caudate. So you have the caudate, the thalamus, and you have this bundle here that would be what would be called the internal capsule. Okay. So what could we just type in the chat? What do you think this area is? Okay. Okay, so lots of responses here. Yeah, so everyone is really correct. So there's putamen, globus pallidus, basal ganglia, which is correct, because the caudate, the putamen, and the globus pallidus all make up the basal ganglia. Okay, so that's correct. I was going to have you mark where the putamen is, but since we've answered that, we're going to move on to the next question. And so I'm going to, don't worry about that. Okay, so there's, I had, so before we mark the midbrain, the slide here. Let's stop and go to, so this is the slide that I wanted to show here, which is saying, so I just wanted to recap on this, which I think Walter talked about. I said, if you're looking at this, you're looking at where the ventricles are, right? You're looking at the shape. The aim of this is not to make you, you know, a neuroradiologist, because even I do not read this every day anymore. But what I want you to figure out is, how am I going to figure out where am I? And in that case, all I want you to remember is, if you're looking at this and you're seeing this shape, you know, this slit-like appearance of the ventricles, then the question that you most likely are going to be asked here is going to be around, you know, these deep brain structures. And so you have the caudate head, which most people got. And what I like here is that you can figure out also the territory of the blood supply that's supposed to be in this area. And then the putamen and the globus pallidus, all of them are very well connected together. Remember I said this is the internal capsule. I hope that by the end you'll hallucinate, because we're doing a lot of repetition, that you can see the internal capsule. I said this is the corpus callosum, which allows, you know, the right and the left cerebral hemispheres to communicate. And then the thalami are in the midline here, okay? And Walter is trying to remind you, you know, basal ganglia from the telencephalon, and I'm also trying to point where the vascular territories are in this case. So you can see that the thalamus gets its supplies, you know, from the posterior cerebral artery. There's also an anterior choroidal artery that supplies the internal capsule. And then this usually is the middle cerebral artery territory. And this is where the globus, the deep branches of the middle cerebral artery, if you have a stroke there, then you have symptoms related to the function of the globus pallidus and the putamen. Really, all these are the basal ganglia, okay? I'm going to move on again. In this case, we're going to do a little more polling. So I'll make the transition, thank you, Dr. Newsom, for the feedback, a little bit more smoother towards, could you mark the midbrain? You can mark them on both. I mean, people really know this area, so. Okay, so I'm going to lock the response, allow people to get back to the presentation. Guys, this is not the midbrain. That one is too far off. Okay. And I just wanted to recap a place that, you know, so this is the medulla. I'm just going to assume that these areas are maybe a mistake, but most people are correct, and this is the midbrain. And I want to just talk a little bit. Walter showed these areas last time, and this is a picture of the midbrain. So there's something that's going to help you remember here. Remember, we looked at the fourth ventricle, and then we looked at the lateral ventricles, and I have a picture of this, and they communicate through the cerebral aqueduct. So if you think that you're cutting across axial view through this level, where you're looking at the midbrain and you're looking at the cerebral aqueduct, then you can see, as long as you can identify where the aqueduct is, then you're at the level of the midbrain. This is how you would know, and then now you can cram the rest, because there's just no other way to do it, you know? And so I'm going to show you this from an MRI perspective. In this case, what I've done is, I said, this is the midbrain, and you know, I'm cutting through across, and you can see sort of like this is the midbrain here, okay? Now, if you look at it, you'll say, Judy, why does it look the opposite way of what Walter showed us? Now, remember, the cerebral aqueduct is posterior, right? So the best way to look at this is almost to flip it, you know, where I just rotated his image, where the cerebral aqueduct is posterior. And in that case, you would look at it and say, okay, I can see that this is the, you know, if you flip it, this is the posterior part. So you're looking at it the opposite way, and you can see this V area now becomes correlates to this anatomy. And so the examiners will always try and trick you, you know, and will say, you know, they're just going to, and you're tired, it's a long exam. What you need to figure out is, where am I looking at? What view? And what are some of the landmarks? For these deeper structures, I really encourage you to use the ventricles, because they'll always help you figure out where you are. And so if you look at another example here is, you know, let's say, let's mark the pons, right? We don't have to, but you can see that this is the pons, and really this would not be the pons area, because this is the midbrain, if you remember the picture that I showed you previously. And if you mark the pons area here, you don't have to do it. Okay, you can do it. Someone beat me to it, but yeah. So this is the pons area, and okay. I'm just going to go ahead, just go back to the presentation for now. I'll let you know when you need to go to the paw view. So if you look at the pons area here, at this point, I think it's best to, okay. Are you still able to see my screen?
Yes. Oh, we're not. We're seeing your slides on the side as well. So if you go to,
yeah, okay, yeah, I think like the images are pretty big. So I just want to walk through this idea that I'm explaining about so yeah, so about the views and rethinking about the role of the ventricles. So if you look here, and I'm going to play this, and I'm going to start from the top here, which is the cerebral hemispheres, going down through the anatomy to allow you to wrap your head around, you know, how do you use the ventricles to tell you where you are. And so if you look, we're going down. At that point, we are at this slit-like area of the ventricles. So if you look here, we are at this slit-like area, not yet. So I'm cutting through these lateral ventricles here. They appear slit-like, and I said at this point, when you see this picture, you should be thinking these deep structures that you're going to be asked about: the caudate head, the putamen, and then the thalami, which are kissing, you know, these ventricles here, and this would be the internal capsule. This is the corpus callosum. If you move ahead a little bit to the next level, this is the interthalamic, I think, fissure. And then if you move just a little bit forward to where you're seeing this midbrain, where we're cutting it, this is the picture that I just flipped from what Walter had presented last time. and you can see this sharp split. And the cut here is always to look for the cerebral aqueduct, which is really the third ventricle, very, very tiny. And that's how you'll remember that. And then if you go ahead to the pons, you can see it's almost like a tooth, right? Like a molar tooth here. You can continue to imagine it that way. And at this point, what you're seeing posteriorly should be now getting to the third ventricle, to the fourth ventricle. And as you, Dr. Nisam, do you mind muting your microphone? And so as you go lower, you'll see now you're going to start getting to the this is just the communication of the cerebellum, that they have to sort of communicate between each other and then come back to the brainstem. And as we go along further, you'll start to see we are now cutting into what would be the medulla, which doesn't have a very specific shape, but you're looking here and you're pretty low in the cerebellum. And you can see that you're starting to see the level of the eyes, because this is where you're cutting the field, and you're going to get into the spinal cord, okay? So that's sort of like what I wanted to talk about. This is really what I went through right now, is just how to use the ventricles to help you figure out where are you in this spectrum and how you correlate this to another view. Remember, the pons looks like a molar tooth, and then the midbrain has that V, but you just have to remember, try and figure out where the cerebral aqueduct is, and that you don't get too overwhelmed by the flipping, because people will do that to your exam, okay? So I wanted to recap again here in terms of cranial nerves. Walter went through this. Like I said, if you're joining us later, this is a companion lecture to the last one. It's online. You should go back and rewatch it, and hopefully this is going to sort of tie some things back home. Remember, the eyes and the nose are here, right? And so because you're cutting, straight in the midline, and so of the eyes and the nose are here, the number 1 and 2 are in the, in the cerebrum, and then in the midbrain we'll have the 3 and 4, and then the 4s, the rules of 2, 2, 4, 4s. So in the pons, you'll have 5, 6, 7, 8, and in the medulla, you'll have 9, 10, 11, 12. And so please go back and revise what Walter talked about, the eye symptoms and everything else. Remember, if this is we'll have an ophthalmology lecture, so I didn't spend time on that, but if this is the pituitary gland, remember the optic pathways come across here. And once that happens, is that we will have, this is where you can get the eye lesions. And so if you just sort of remember some of these basic things, they can help you troubleshoot even if you don't know what's wrong. So remember, up to now, we've not talked about any lesion, because I want you to figure out localization. Because if you can localize in the brain, then it's easy to figure out what's the problem. So back to Paul everywhere. So what is X? This should be easy. People have been doing very, very well on this. What structure is X? Sorry, when I made this lecture, yes. So the lateral ventricle. I made it because I wanted us to have lots of repetition, and if I move from a different view, then we should be able to come back and see. So I'm going to stop the poll. Please come back to the presentation. I'll give you a few seconds to do that. Correct, this is the lateral ventricle. Again, if you want to figure out where you are, if you're seeing this slit-like appearance of the ventricles, then you're saying this is the caudate head, the putamen, and the globus pallidus, the thalami. And it's just because you're only identifying this level because of the shape of the ventricles. Okay. Yeah, so we've beaten the horse of the ventricles pretty well, I think. But there is a slide that's missing here. So I'm just gonna, maybe what I'll do is reload my talk here. because this is the slide that we should be on. So I wanted to go through the anatomy of the ventricles. And I think neuroanatomy and pathology, you have to think about anatomy a lot and use that to help you. So we've gone through these lateral ventricles. I've shown you many times. Depending on where you're cutting them is where you get that slit-like appearance. It helps you. I've gone through the third ventricle, which helps you figure out where you are in terms of the midbrain, right? And well, not the third ventricle, but the aqueduct of Sylvius. And then these are the the inferior horns of the lateral ventricles, and then you have the fourth ventricle. And the fourth ventricle usually will empty through a middle and lateral folds, and those are called the Luschka and Mogeni foramen, Luschka and Mogeni. Remember, examiners love buzzwords, right? Anything that is named is examinable. And so the CSF is usually generated by the choroid plexus, and goes through the third ventricle, and it goes through from both lateral ventricles through the interventricular foramen of Monroe. And once that's done, it goes through the third ventricle, through the aqueduct, Sylvian aqueduct, and then into the fourth ventricle. And then, depending on whether it goes laterally, L for Luschka, L, M for middle, Mogeni, and then it goes through this subarachnoid space, and then it's absorbed in the superior sagittal sinus. And this is important for understanding pathology, because if you have an intracranial hemorrhage or something that's blocking the subarachnoid space, so specifically subarachnoid hemorrhage, then you have problems in absorbing the CSF, and then you end up having this non-communicating hydrocephalus, because your ventricles are big and they're not being able to drain, okay? And unlike in something like normal pressure hydrocephalus, where you have just diffuse enlargement of the ventricles. So understanding this pathway is going to help you figure out, is this a communicating hydrocephalus or a non-communicating hydrocephalus? I want to talk about this in terms of pathology a little bit. And this is because the choroid plexus, if it's producing too much CSF, then you'll have a communicating hydrocephalus, and this could be a choroid plexus tumor or something, in the congenital area, okay? And so remember, everything here is fixed, right, in the brain. You have blood vessels, you have CSF, and you have brain. If one expands or one goes down, then something else has to expand to fill the space. So for example, if you have a head injury that's bringing now a new hematoma on the side of the brain, then you have to push something out, and that's when you get herniation. If you have, if you have loss of, you're very thin, you have loss of brain matter, so you have increasing spaces, it stretches out the vessels, and usually the dynamic regulation is usually blood supply. So super important to understand the pathways for CSF flow. And I just really still wanted to run this again for you to see the slit-like imaging, that's just these ventricles. And then we talked about the third and the Sylvian aqueduct. So in terms of gamesmanship, when you get a place where you see the ventricles are big, right, you have to ask yourself, what's the age of the patient? If it's like 2-year-old, then you should start to think this is more, could be meningitis, right, if it's non-communicating, but because, the inflammation of the meninges affects the CSF absorption. But if it's, you have to think about congenital causes, and then you have to think, is it because they have tumors? That's why it's compressing the third ventricle. And so I really encourage you to walk through this sort of algorithm. If you see enlarged ventricles, can you figure out if they're communicating and non-communicating? Remember, just seeing, you have to see all of them enlarged for it to be a communicating hydrocephalus. And then you have to think, it's either that you are not, if it's communicating, you're either producing too much CSF, or and there's no obstruction or absorption of the CSF, that's in the subarachnoid space. And I think we've talked about communicating. So this is how to approach questions on hydrocephalus. I just wanted, because I'm going to shift gears here to something different. I know we are past the hour, but I'm rushing, not too many slides more, is that you always have to think about, if you see these views for imaging, use them to help you figure out where you are. This is the view we've gone through many times. It's a classic view. All of you performed very well to figure out where the anatomy is. I'm just moving now on the sides when I come to these other views, right? So you start to lose the, you know, the CSF spaces, but you can definitely see the lateral ventricle, and you know that the corpus callosum, this white area, because it's a band of white matter, sits on top of the ventricle. And also the white matter is what forms the cord and the brainstem. Okay, because those are tracts that they have to supply things. And if you're moving here, then if you see, well, I cannot see I cannot see, or these ventricles are in the canal here, then you start to think, okay, maybe this is a Chiari malformation. It's also going to have associated hydrocephalus, usually when they show it to you in an exam situation. Or usually they don't try and trick you, like it's not an eye test, like something very difficult to see. I wanted to talk about this lateral view here a little bit, because this is the temporal lobe, you know, frontal lobe, you know, occipital lobe, cerebellum, and then we have parietal lobe. Walt already talked through what big structures in terms of speech and language and handedness come from these views. Okay, so moving on to blood supplies. I talked a little bit, remember everything always has an artery, vein, and lymphatics. For right now, we're going to focus on venous systems. If you do not mind, can we go back to the pole and mark where you think the superior sagittal sinus is? Okay, let's come back to the presentation. Okay, so this is pretty all over the place. And so the superior sagittal sinus is this one. Now I can so this is a view where you see the blood vessels very well. And again, it's still sagittal of the brain, because you can see the nose here, right? It's just the same thing like the MRI. You can see the sella here where the pituitary would be, okay? And what I think that you may confuse you, this bright stuff on the this is like white, right? It's like my slide here. This is bone, okay? And so, and black is air. So you can see the nose has air, you know, the airway has air. So this is the skull, the people who put there. This is the skin, and this is the brain. And whatever is between, you know, sort of middle line, superior most, where some people have put in some marks, would be the superior sagittal sinus. Okay, I'm going to clear responses. Could you show me where you think the inferior sagittal sinus is? So back to the poll. Okay, I'm going to show the responses here. Oh, okay. Sorry, poll is locked. Show me where you think, yes. Okay, good. So just in the interest of time, I'm going to, okay, so this is much better distribution. I'm going to lock this and just go and recap where all these vessels are, okay? Don't worry about this, because, oh, okay, let's do this actually. And then I'm going to show the correct answer to the other one. Let's go back to the poll everywhere and do, what's this? So you said this is the superior sagittal sinus. Okay. We have straight sinus, sigmoid sinus, and boom, vein of Galen, transverse sinus, great cerebral vein, sigmoid. Okay, I'm just going to lock this. Let's come back to the presentation. Definitely not inferior digital. Okay, so back to the presentation. And so here is a recap. This is the superior sagittal sinus, like I mentioned. This is the inferior sagittal sinus. Okay, superior sagittal sinus, inferior sagittal sinus. Then you have these thalamostriate veins, which join in and form the internal cerebral veins. And this becomes the vein of Galen. And the inferior sagittal sinus and the vein of Galen join together to form the straight sinus. And at that point, the straight sinus and the superior sagittal sinus form together to form the transverse sinus, because it's coming transverse, then sigmoid, and then it becomes the internal jugular vein. Okay? So in this case, if I can convince you, this is very bright, this is dull. This is a patient with a thrombosis of the superior sagittal sinus. Okay? This becomes more important in step 2, where you think of pathology. Okay, but I wanted to recap that. And so the sort of my next area here is, hopefully this play now, is I wanted to show you another type of interventional radiology that I do not do, but Dr. Newsom used to do, is in the brain. Okay, so what I'm showing here is a cerebral angiogram. Okay, maybe I can stop it. So this is an injection through the right internal carotid artery. Remember I said handedness is flipped in radiology. So this is not the left side of the patient, it's the right side of the patient. You can see contrast similar to the first case that I started with, right? And you see something coming more middle and then something coming lateral, okay? So this is the anterior cerebral artery and then middle cerebral artery. We can see another view here. So that image that I showed you, someone is taking a picture straight at the patient. Now this one, someone is taking a picture lateral to the patient. So this is still the same injection. There are many parts of the internal carotid artery, but you can see something like this very characteristic appearance of these vessels of the anterior cerebral artery and then the middle cerebral artery. And so this, if you imagine a mirror image now, because you have to go through the left carotid artery to inject it, then you can see that if you're imagining this, then you'll see that how the circle of Willis is formed, right? Anteriorly, because you have this bilateral right and left anterior cerebral arteries, then the middle cerebral arteries, and I'm showing them again here, middle cerebral artery, the anterior cerebral artery, and then the posterior circulation, because I can maybe help you see that this is the skull here, and we have this blood supply coming from the back here, supplying the back of the brain. And the anatomy here is interesting because you can see that this injection, shows two different vertebral arteries, okay? Then they come up together to join into the basilar artery and then terminates at the posterior cerebral artery. So anytime you see a CT scan, okay. I mean, I know we are beyond time, but I'm almost done. These are like my last slides. So for humor me by trying to answer, what do you think is the diagnosis here? This question, a bleed. Hydrocephalus, intracranial hemorrhage, subarachnoid hemorrhage, thrombosis, a clot, hemorrhage, hydrocephalus, ICH. So I'm going to lock the poll if you want to come back to the presentation. And so this is subarachnoid hemorrhage. Okay, this sort of like where it's located. It's good. You can also see it more in the subarachnoid areas, and agree that there's hydrocephalus, because remember the final pathway of CSF is absorbed in there. Is absorbed in the. There's one more slide I want to show you here. The final pathway of CSF is absorbed in the pathways for the brain where there's a subarachnoid space. And so if you look at this study here, I'm going to show you, you can see the brain, big ventricles. The fourth ventricle is small, but so if you look at this, the fourth ventricle is small. Still the same things that you should be thinking about. Where am I looking at? This is sort of that same view for the slit eyes of the ventricles. This look much bigger if you look at the MRI. This is still the caudate head, right? Kissing the frontal horns of the lateral ventricle. At this point, you'd have the thalami. These internal darker areas would be the internal capsule, and this would be the putamen and the globus pallidus. These are posterior horns of the ventricles, and as you go down, you see the third ventricle is big, the posterior horns are big, the fourth ventricle is not big, and then you have this wide. And so this is subarachnoid hemorrhage causing obstructive hydrocephalus, which is a known complication. Okay? And so what I wanted to talk about in terms of gamesmanship, when you see a CT scan and white stuff, you have to figure out, you can get secondary things, right? Like if you can see hydrocephalus and you just have to cram this, look, this is pretty dramatic. You know, then you know that this is, and Bernard says there's a star here, which I agree. You know, so then this is subarachnoid hemorrhage. If you see this type of white, like completely white, remember this is bone. If someone is trying to show you like a fracture, then they'll show you the bone window. And if you're seeing anything white, you're either thinking, where is am I in the correct place where I expect a blood vessel, or am I having blood? And so location and expectation of where you are is a big deal. And so one thing that I wanted to just sort of conclude, and I can answer a question, is that be prepared to see something familiar in an unfamiliar format, right? So you know that, you know the blood vessels, right? But if someone shows you this and says, name this, you know, it just completely throws you off if you've never seen this type of pictures, you know? And then if you say, you know, if you see like the CT versus the MRI, right? You can see that with just using the tricks that I mentioned about the ventricles, you can figure out where you are. and you can, sort of guesstimate how things are. And there's also like a lot more in terms of gamesmanship, in terms of some of the words that are being done. But people are increasingly very clinical, and the question will be a radiology question, but it's not going to be, it's going to still be like an embryology question, but requires you to have identified the pictures. And so there's this thing here in America, Waldo. It's a pretty common game where you're supposed to look for this guy in this mess. And if you're doing many cases, 8 hours, you're tired, you're doing hundreds of questions. So you have to figure out how are you going to remember even when you're most tired, to make sure that you're not missing this high yield and quick marks for you. And then this type of next level questioning where, like, I could say, tell me where the X comes from. So you have to identify that X is this organ, and then where is it the telencephalon, the diencephalon? Those questions require you to sort of have a dual view, and that's sort of needed. And then always keep it simple and short. Find a way that works for you. If you're looking at imaging, figure out in the brain, I think the ventricles are the big landmarks to help you figure out whether you're on CT or an MRI. And then try and organize your learning when you sort of synthesize it into a form that you can understand and remember when you're tired, okay? And also in a different time zone, depending on where you do your exam. So in radiology, you always have to remember the views and what's best visualized on a view that you're not seeing. So we didn't even go through the coronal view. So I'll open the poll here for some feedback. What do you want to learn next time? Should we stop these lectures? How is your experience going with this? You can put it on the poll. You can put it on the Q&A. I think my style with Walter has been to try and get engagement a lot, but let's see. Okay, Pauline said totally worthwhile. Your pace is perfect. Thanks, Pauline. Sorry if it was too basic, maybe too slow for some. Okay. Okay, Bernard says, my only request is radiology should be given some more time. It's everyone's nightmare. More time. But then you can also say bad things. It's okay. That's why we brought Dr. Newsom here, so that she can buy us lunch if we're sad. Okay. So what do you want to learn? Like, what topics do you want to learn? I think we can get people to do this. We're still learning. Today I tried the pollen because I thought embryology. Okay. I try to use the poll everywhere because, and I understand. I think it's a little easier because I have 2 screens, but it may not be easy if you're watching from, most people who may not have like 2 different devices. Maybe a laptop may be better, but I wanted to see if it's easy to understand from, if it's easy to understand, sort of, instead of like jumping to and from. But we'll figure it out. I think we keep getting better every time. Okay. Walter, what do you think?
Yep. Thank you, first of all, Judy. I mean, that was amazing. Looking at those pictures from whichever view and identifying structures, that was amazing. I really enjoyed the session. And I think we will, I think Victor said that he has some list of what they like to be taught. And I see embryology from Lydia. And, we're going to engage many more people to come on board. And we have a couple of weeks which we have some scheduled events. we were supposed to have, is it ophthalmology next week? But if it's not there, I will come up with something in neurology for next week. And the week after we'll have, I think, ophthalmology. Then the week after we'll have ECGs and EKGs.
So, I mean, yeah, Pauline says, please tackle the lesions arising from blood supply. So on the next one, I can just show you, we can do like a quick rapid fire of close to 100 cases. But
awesome.
if people will come with if people will come with like, the polling has to be more seamless, you know? I think it worked out well towards from after the first case, but I just, because then I can show you like, you know, localization, and we're just going to go pretty quick, and you can just say, okay, what's this diagnosis? And then we can see what are the big things you need to remember, what are the buzzwords, so we can go much more high yield, quick, not more of like the basic way to review. So that would be like a follow-up to this type of question, you know, where I would say, for example, like the stroke, where I show you the picture and you say, where is this coming from? You know, so more question oriented. But I thought it may be a little bit too much to have you answer a question if you've never even seen. The first time I saw a brain MRI really was when I started residency. I know that's definitely changed. But
I think Dr. Gichoya, I think I like that. We can do that next week. And so that it's continuity of what we have been doing for last couple of days. Yeah.
Okay, guys, we're trying to keep this 1 hour. Sorry, this went on beyond 1 hour, but mlale salama, and it's still morning. Well, actually lunchtime here. Asante sana.
Thank you, guys. Thank you, everybody. Have a nice weekend.
Yeah, final words for our trainees.
Oh yeah, so for the attendees, thank you for coming. We will engage so many people from the United States. You know, even Dr. Newsom has not done any presentation. So I'm really looking forward to having her presentation. And
Walter, you're shaming me, and that is not fair. But I will contact you and Dr. Gichoya. It is possible that we can have a surprise presentation next week.
Oh, awesome. I love it. So thank you so much, guys. Keep watching on your WhatsApp pages, and we're creating also a website so you can get all that information out there. And thank you, and have a nice time. Thanks, Judy. Thank you so much for the energy and all you gave us today. Thank you so much. Appreciate it.
Bye.
Mm-hmm.
Let me end this.